Good morning, everyone. I am Dr. Tanveer. I'm one of the consultant neurologists at Lancashire Teaching Hospital NHS Foundation Trust. It's my privilege to be in front of you and presenting this work we performed as part of my MasterClass project. This work was carried out by myself and my colleague, Dr. Wall, Dr. Muskery, and Monica Arthur. It's titled An Audit on Consenting Process for Ocrelizumab in Lancashire Teaching Hospital NHS Foundation Trust. Briefly, we all are aware that ocrelizumab is licensed for treatment of relapsing remitting multiple sclerosis and primary progressive multiple sclerosis in patients in UK. In Lancashire Teaching Hospital NHS Foundation Trust, this treatment is administered at the Neurology Day Treatment Centre. Before this treatment is offered, the patient undergoes a rigorous screening process after the MDT panel has approved the treatment. And following the screening process, the nurse specialist will discuss with the patients the intended benefits, the risks, and also how they will be monitored. On first day of the ocrelizumab infusion, the patient would attend the day treatment center, and a pre-infusion consent is performed and obtained by the neurology registrar. It is important to mention here that because of the rotating pattern of work, the neurology registrar is not set in the unit, and as they rotate every 6 monthly, we have a different neurology registrar who might be consenting the patients. We usually use a generic trust consent form for ocrelizumab consenting, where the neurology registrar would document the discussion that has undertaken with the patient, including the risks of the treatment. As we are all aware, consent should include frequently occurring risks. It should also include the serious risks. However, it should not have any risks that are purely speculative and not substantiated by evidence or theory. This is how our consent form looks at the moment. This is the generic consent form where we have to put the patient details, and then we discuss about the post-procedure for the course of treatment and the intended benefits. There's an open space to write down the intended benefits, and also the serious or frequently occurring risks as they're discussed with the patients are documented. Following this, the clinician will sign the form and the patient will also countersign the form. When I was a registrar, it was clear that there were gaps in the process as well. And as I mentioned that we rotate through different farms. We are not with just the MS farms throughout the rotation. So there can be gap of how the information comes to us and how we relate to the patient. So the aim of this audit was to evaluate the variations of information and risks discussed during the consenting process for ocrelizumab. We decided to take some steps to improve the quality of the information provided during the consenting process of ocrelizumab, and subsequently, if there is scope, to develop a treatment-specific consent form to assist the clinician, and that will hopefully help to reduce the variance in information provided to the patients. We set the audit standard at the very outset. We could not identify any previous audits of this category, and we decided to set a very high standard that the following risks must be discussed with the patient during the consenting process, and we aim to achieve 100% compliance. The common risks should include the mild infections, including the upper respiratory infections, nasopharyngitis, hepatitis B reactivation, skin infection, herpes infection, and they should also mention about the minor infusion reactions. On the serious risks, the consent form should have the risk of immunosuppression and risk of serious infection discussed. The risk of serious infusion reaction, including anaphylaxis, should be discussed with the patient. PML, though it's a very rare complication, can be potentially life-threatening and should be discussed with the patient. We should discuss the risk of fetal malformation to women of childbearing age and also to male. And the risk of malignancy should be discussed, though trial shows that there's increased risk of breast cancer, including incidence, though the frequency is unknown. We decided to get the case notes of 10 patients, and these were selected randomly from the past 18 months since the commencement of ocrelizumab. The inclusion criteria for this audit included that they should be commenced on ocrelizumab, and the consent form should be available in the electronic patient's record. When we looked into the data, it appeared that out of the 10 forms, upper respiratory infection, risk of upper respiratory infection was discussed only with 2 patients. The risk of nasopharyngitis was not available in any of the consent forms. Flu-like illness was discussed with 2 patients. The risk of hepatitis B reactivation was only discussed in 1 case. None of the consent form had risk of herpes infection, gastroenteritis, skin reaction, or hypotension discussed. Minor blood abnormalities, including lymphopenia and hypogammaglobulinemia, was discussed in 5 cases, and minor infusion reactions were discussed in 7 out of the 10 consent forms. With regards to the serious risk of immunosuppression, it was discussed in 5 cases. The risk of serious infections was discussed in 10 cases. The risk of anaphylaxis was discussed with all the patients. The risk of PML was discussed with 8 patients. Fetal malformation was discussed in 4 cases. The risk of malignancy was discussed in 5 cases. Other issues that we identified during the process, that one of the consent form was ineligible, and kidney and liver failure was discussed in 2 cases where there's no evidence from trials. So after we went through the data, we realized that there was a wide variation in the information provided to patients during consenting for ocrelizumab in our trust. This could be in fact the same for a lot of the trust, where there is not just one dedicated person who will be consenting all the patients, or that there is no structured consent form. So we thought that we could rectify this by using a treatment-specific consent form, where the common and the serious risk of treatment are available to refer to and explain to patients by the consenting clinician. This audit was subsequently presented in our local and trust governance meeting, and a proposal was made that we develop a treatment-specific consent form to assist the consenting clinician. We came up with a list of information that should be available in the ocrelizumab consenting form, and this includes the common risks and the serious risk, as you can see. This is how our new consent form will look like. This has now gone to press for printing, where we discuss with the patient that they are being offered ocrelizumab for treatment of multiple sclerosis. The intended benefits include reduction in the rate and severity of relapse in case of relapsing remitting multiple sclerosis, and also to reduce the acral disability due to multiple sclerosis. The common risks and the serious risk are discussed, and subsequently the patient and the clinician will sign the form. Other treatments that are offered in this trust in the day treatment center are natalizumab and also the first dose fingolimod. The consenting is also carried out by clinicians in these cases, and based on the findings from this audit, we decided to develop a treatment-specific consent form for natalizumab and fingolimod as well. We hope that this process will reduce the variance in the information provided to patients during the consenting process, and we aim to re-audit after 1 year and make further changes based on user experience. Thank you very much for your time.